Dr. Robert Moffitt is a Senior Fellow in the Center for Health Policy Studies at the Heritage Foundation in Washington. Dr. Moffitt's research interests include the Medicare program, entitlement reform more broadly, and the criminal justice system. He's also part of Heritage's Center for Policy Innovation, which is charged with designing the next generation of breakthrough policy ideas at the Foundation. Earlier in his career, Dr. Moffitt held senior positions at HHS and the Office of Personnel Management. And Dr. Moffitt served with the Maryland Healthcare Commission from 2004 through 2007. So welcome back, Dr. Moffitt. Dr. Andrew Pollack, to my left, is the chair of the Department of Orthopedics at the University of Maryland School of Medicine and is the James Lawrence Kernan Professor at the School of Medicine and a section chief and practicing surgeon at Shock Trauma. Dr. Pollack publishes extensively on trauma injury and treatment, one of his principal clinical interests, and he has served in leadership positions at the American Academy of Orthopedic Surgeons and the Orthopedic Trauma Association, and Dr. Pollack was also a Maryland Healthcare Commissioner from 2004 to 2007. Welcome back. Last but not least is Jeffrey Metz, who is the President and Nursing Home Administrator of Eagle Nursing and Rehabilitation Center in Lonaconnie, Maryland. Mr. Metz has been active in numerous community organizations in Allegheny County. He has also served as an elected member of the Allegheny County Board of Education. Prior to joining the Commission, Mr. Metz has served as the Vice Chair of the Maryland Board of Examiners of Nursing Home Administrators. Welcome. Commissioners, you've received the written updates from our centers. Ben, do you or any of the center directors have anything you'd like to add to your update?
Thank you, Mr. Chairman. I wanted to, first of all, say normally at the end of the session, we have in that following meeting an update from our legislative director on what has happened during the past session. As the session just ended on Tuesday, and we're still sorting that out, we've decided to defer that until May, but we will be providing a comprehensive summary of what has happened and its impact on the Commission at that date. I might add that this year we're still somewhat sorting out everything that happened because there are a number of informal requests that may be coming to the Commission over the next several weeks that we'll be able to provide some clarity on. I also wanted to start a process in which we get a chance to recognize staff members that typically don't get as much opportunity to present to the Commission, but are doing very important work. And I wanted to pick two today. The first is Kathy Weiss, who's in our Health Facility Planning and Development Center. Kathy's been leading the effort on redesign of our state health plan for home health agencies. That is quite a daunting effort as we try to build more flexibility into that chapter, give both agencies that are already established in Maryland and those that would like to offer service opportunities to serve residents of Maryland. She's done a great job in developing a established and those that wish to provide service. The other person, Kathy, if you just want to stand. The other person is Ken Trotman, who is with our Center for Analysis and Information Systems. Ken is a practicing actuary and has been working closely with the Maryland Insurance Administration in an initiative to align our all-payer claims database, what we call the medical care database, with the MIA's efforts to conduct rate review. It's an important application of the medical care database as significantly. We think it can reduce the workload for carriers ultimately that would submit rate filings to the MIA. It will also enable the MIA to have greater scrutiny and greater opportunity to drill down and understand the nature of rate increases, as they will be able to use the very detailed claim information in understanding what's happening to healthcare utilization and whether those premium requests are justified. Ken's pretty much our front-facing person with the MIA, and I've gotten good reports from MIA on the work that he's done, and we really want to thank him for his single-handed effort. So, Ken, if you're here.
All right. Move on to agenda item number 3, which is a certificate of need approval. William Chan, Health Policy Analyst, will present the staff reported recommendation regarding a requested second modification to the certificate of need awarded by the Commission in December 2012 to the nursing home known as College View Center, which is located in Frederick, Maryland. Okay.
Okay, as was stated, the applicant is College View. They are a subsidiary of Genesis Healthcare in the process of building a replacement nursing home in Frederick. Their current facility is 119 beds, quite old, and the new facility, in addition to replacing those 119 beds, had acquired 11 beds from another facility, actually at the hospital. This is the second time that the applicant is before the Commission asking for a modification of that CON. It's a modification to reflect cost overruns. And I know we've got new commissioners, experienced commissioners as well, so they may know about this, but I thought I should back up just a little bit to give some background on when a CON is issued. There is a certain cost associated with that is approved, and an allowable inflation increase based on a building cost index. If an applicant finds that the project is going to exceed that, they need to come back before the Commission for a modification. And as long as the project doesn't change the fundamental nature of the facility, doesn't increase the licensed bed capacity, or require any extensions of time to meet applicable performance requirements, it is then eligible to be considered for such a modification. This project was first approved in December of 2012 for a cost a little bit in excess of $19 million. Subsequently, in July of 2014, came back to the Commission and got a modification. At that time, due to project delays, there were a lot of engineering issues. Bids came in higher than expected. And the projected cost at that time was about $20.5 million, and that modification was approved last July. Since then, the project has continued to have some difficulties. The contractor did not perform well, apparently, and building was not watertight, and there was a significant amount of damage. The contractor has now been changed out, and long story short, they're going to have to tear down about 25% and rebuild. This is leading to a cost increase of about $6 million over the previous modification, which is well in excess of the allowable inflation increase. The additional funds are going to be provided, about $1.5 million out of the reserves of Genesis, and about $4.4 million coming from healthcare REIT. In the staff review, although the increase in the project cost is significant, especially given the significant resources of Genesis, which I failed to mention, they operate about 500 skilled nursing facilities in 34 states. And we'll be standing behind this project. So despite that cost increase and the impact that it will have on the projected profitability, staff did not think that economic viability was in question. There are no material changes in the nature of the project, the location, or the capacity of the project, so the modification does not change the earlier findings regarding need for the project or impact on existing providers. Nor will it have a significant impact on the rates that will be paid. Medicare and Medicaid are the primary payers, and there is a cap that is not going to change as a result of this cost increase, so public funds will not be tapped any more than they normally would be for this project. As noted in the staff report, the projected profitability, however, will decline significantly. The applicant had projected a profit last July in the modification of about $700,000, is now projecting that to go down to about $180,000. I should note that that number does assume a higher Medicare proportion than they're currently serving and higher than that in the county. So staff did ask for an alternative scenario that would show a payer mix that was closer to, actually, that would mimic the payer mix that is currently seen in Frederick County. At that payer mix, there's a projected loss of about $180,000. The applicant also presented an alternative scenario with Medicare at about 24% instead of the county average of 21%. At that level, the loss decreases to only $27,000. And again, if they are successful in attracting the number of Medicare patients that they are projecting, or if they are somewhere in between the alternative scenario and what they are projecting in the modification, they'll most likely at least be at break even. And again, with the resources of Genesis behind this, we did not feel that economic viability would be threatened, although profitability might be. At the same time, because of the unfortunate mishaps tied to the construction of this project, the applicant is also requesting an extension of the performance, a 6-month extension of the performance requirement of having the facility open. Staff recommendation is to approve both of those requests. With us today for the applicant is Natalie Holland, the Vice President of Development, Robert Sanderson, the Vice President of Property and Construction Management, as well as legal and CON consultants Howard Solins, Jack Eller, and Andy Solberg.
Terrific. Let's start with, can I get a motion to approve the certificate of need? Second? All right.
Second.
Open it up for discussion and comments. And is there a commissioner now on the phone?
Ligia Peralta has been on the phone.
Okay. Welcome, Dr. Peralta. Any questions or comments? Fran.
Thank you, Mr. Chair. Thanks, Kevin. Could you talk to this condition that staff is recommending be placed on the approval?
Oh, yes. That the original condition on the CON and the one that we would carry forward on this is that the applicant would, before first use approval, execute a memorandum of understanding with the Medicaid program to, at minimum, meet the required amount in Frederick County.
So you talked about various assumptions for the case mix. Just to follow up on that, for the case mix, meaning I think you're talking about the percentage of Medicaid versus Medicare. That's
and private pay as well.
And private pay.
So
there's different projections with resulting differences in either profitability or loss depending on that case mix. Right?
That's correct.
So I'm not understanding what the COMAR regulation would hold the facility to. It seems like that there's a proportion that's written into COMAR.
All of the applicants' projections, whether it be their original projection or the projections that the staff asked for, the alternative scenarios, would all at least meet that minimum Medicaid requirement. In fact, there would be, under the scenario that the alternative scenario we asked for, the patient days would be 53% Medicaid, 21% Medicare. The applicant's projection was 39% Medicare, 45% Medicaid. So they are, even at their initial projection, they would be in compliance with that memorandum of understanding. So it's really a matter of, maybe they would want to speak to this, but I think it's really a matter of how successful they are in terms of attracting Medicare patients. I think with the new payment system and the emphasis on keeping people out of the hospital and decreasing readmissions, there's really a push across the industry to serve Medicare patients and to help hospitals meet their goals. And Medicare is the best payer. So, you know, the financial incentives as well as some of the dynamics right now in the delivery system are feeding that trend to nursing homes seeking more Medicare patients. But I have to stress that, you know, they would be signing that memorandum of understanding, and all of their projections are consistent with that requirement.
So what is the requirement?
I think it's 40. I think in Frederick County now it's 43%. I couldn't tell you exactly.
So in COMAR, for every county, there's a particular case mix requirement?
We collect the data on the percentage of of days across each jurisdiction that are Medicaid. And the MOU requires an applicant to be at least, they have to be at least 15%, within at least 15% of that district-wide average, that jurisdiction-wide average. Did I get that wrong?
I'm just trying to clarify your question. The COMAR requirement in the state health plan concerns only Medicaid. And basically, the facilities have to meet the percentage in the jurisdiction or region, whichever is lower, based on Medicaid days as a proportion of total days minus 15.5. So just to clarify, the COMAR is only Medicaid, and what Kevin is saying is they have met that requirement.
Thank you. Thank you. That's helpful, because I guess my underlying concern is that we're not squeezing out Medicaid patients in order to take a higher revenue in order to take Medicare patients. So that if there's a need in Frederick County for Medicaid beds, this facility is committing to meet the standard that is consistent with whatever that local need is. That's what I'm trying to get at. And so I think it's a little redundant. Explain to me how, if that's in COMAR, that's in the state health plan, maybe this is like belts and suspenders, we want them to also sign an MOU with Medicaid that they will do what the COMAR requirement for the CON requires them to do. So is that, it's a little redundant.
I don't think it's redundant. If I'm misstating this, I'll certainly look for help here. But I think it's related to a facility that came into existence years ago without a CON. I don't think has any such requirement. I think it's when you are getting a certificate of need that you have to commit to that.
Linda, you can stay here if you want.
I thought I had answered it. requirement and enforce it on the facility.
So this is a vehicle or a mechanism for Medicaid to have in hand to do
Yes.
going in the out years.
Correct. It was originally worked out with the commission and Medicaid joint.
Got it. Okay. Thank you both.
Any other questions, Jeff?
Yeah, I'll just comment more than a question. You're correct in all your assumptions that nursing facilities are definitely trying to attract and have Medicare be their driver for revenue. Because Medicaid is all facilities, my facilities that I've worked with typically need Medicare revenues to offset underpayment by the Medicaid system, significant underpayment by the Medicaid system. It might be a little ambitious, the 39%. I did some quick numbers on my calculator with our facility where that would fall out. Probably the alternative scenarios with lower Medicare days might be more realistic, somewhere around 23 or 24%, which puts them at just about break even, which kind of makes sense. And with Genesis being such a powerhouse, then that risk is a lot smaller. My standalone facility, I'd be scared, but with Genesis backing, it would make sense. When I first did the numbers on the cost per bed, when I looked through here, I was like, wow. But when you look at the pro forma, assuming it's correct, then it should be good.
Okay, thank you. Other questions? Dr. Moffitt.
For your 38% increase in cost, revenue. You made a comment, I just want to start. It's improving, so you know it's public funds. Can you give us a ballpark figure? Public funds already expended on the project?
What I meant by public funds was not the capital investment, but in terms of reimbursement by the Medicare and Medicaid program.
Maybe a follow-up to that concerning the accuracy of the projections. And maybe I don't quite understand it, but in my world, when you spend more on capital, at some point you spend more on depreciation, and the scenarios on depreciation look exactly the same. So can someone explain what's going on?
Yes, I asked that question as well. The applicant may want to speak to it if I don't cover it quite well enough, but the business relationship between Genesis and healthcare REIT is such that, and I'm not sure if it's...
Oh, the REIT bears the depreciation?
There's a REIT, and so this is, instead of showing up in depreciation, it's showing up in rental cost.
Got it. Understood. Other questions or comments?
I guess mostly it's an observation, but I find it odd. And in looking at the projected operating results for the full first year of operations, looking at the patient mix, understanding your explanation about wanting different projections based on a more realistic projection regarding Medicare, when the number of in the patient mix, when the percentage of Medicare is reduced, the percentage of Medicaid goes up, the percentage of commercial insurers or the private pay goes significantly down, but it's the self-pay increases tremendously. And the thing that I wondered about that is why such divergent assumptions regarding commercial insurance and self-pay, particularly when looking at the narrative. It also discusses the cost shift that may occur to private third-party payers or those who pay out of pocket, with the applicant saying that market forces will limit the ability to pass on this increase. And yet if thinking about market forces, if the costs do increase, I could understand it would go down for commercial insurance. But why is the assumption that the self-pay percentage would increase so drastically is perplexing to me?
Yes. I'll take the blame for that, actually, because what I asked the applicant to do when we said we want an alternative scenario, I asked them to basically reflect exactly what is going on in the county now. And so their previous estimate had a lower number for self-pay than the countywide experience. So when we asked for an alternative scenario, including a lower Medicare and a higher Medicaid, what also came along with that, using the county averages, was a different self-pay number. And if I would invite the applicant, if there's anything you can do to help educate us on that dynamic, the self-pay situation, the insurance situation.
And just as a follow-up question as you're coming up, was there any discussion about what the current cost is to self-pay and what it may be projected to increase to, particularly given the cost overruns and the fact that market forces may or may not keep those charges at a reasonable level?
Howard Solomon from Overcaler, Stanley Holland. To answer your questions, first of all, I think we agree with what Kevin was explaining and he exactly reflected. First of all, in doing the projections, the rate, the per diem rate to the individual patient did not change. So to the extent that there was a change in revenue, it was because of the percentage increase to model in the hypothetical. So Genesis did not project to impose on the private payers on a per diem basis an increase. Also, market forces being what they are, you can only, it's a competitive market, you can only charge what you're going to charge. Medicare's a RUGS level, Medicaid is is what it is, so they've got to absorb it. So from that perspective, there's not cost shifting. The only thing I'll just take this opportunity to augment is this project is about 90%.
It's about 70% complete.
70%.
Construction we have to do.
Right. This was just an unfortunate situation in which Genesis had to do something that nobody's ever done a capital project ever wants to do, which is to throw the contractor off the site and then bring in people and have engineering studies done and face hard realities and then absorb the costs, which is what's happening here, and they're stepping up and standing behind this project. So this is a project which is going to get the residents in the existing building out of an outdated building. It will get the current space back to the hospital who wants it, and will provide a mix of services as reflects the current marketplace. And I think as Commissioner Metz said, we in our modeling, in our kind of responsive modeling, we use the 23-24%. The only thing I'll say is Genesis has another facility in Frederick County, Glade Valley, which is at 31.7%. So when Genesis thought in a brand new state-of-the-art facility, it was projecting 39. That was not a number to back into to get to a profitability number. That was based on their experience. But I think they do have hands-on experience in Frederick County at 32%. And so, but we wanted to be responsive to the worst-case scenarios that we were asked to model. So there'll be a lot of community benefit. And I'll also say that while we understand the concerns, Genesis just is in the process of doing this in multiple places in the state. It has a successful track record. It just opened what was Knollwood, is it still the name Knollwood?
Watchapel Center.
Watchapel Center, which was a replacement of an outdated building and that you all approved in Anne Arundel County, and they are on track using the same contractor who's now in this building for their Magnolia Center facility in Prince George's County. So they're having good success. This one project was not a good situation, and they're fixing it and absorbing the cost.
Any other questions, comments, or discussion? If not, move to a vote. All in favor? Aye. Any opposed or abstentions? You have your revised second modified CON. Thank you, Kevin. We'll move to agenda item number 4, which is the recognition of an alternative institutional review board. Linda Bartnitska is going to request that the Commission approved the DHMH Institutional Review Board as an alternative IRB that under Commission regulations could assist the MHCC in its evaluation of requests for data, including data in the medical care database. Linda?
Yes, hi. Thank you. Hold on here. I just want to, the arrows. Where are the arrows? Okay, yeah. Oops, wrong.
Enjoy the rest of the day.
Okay, Judy. All right, so there's only one slide. This should go pretty quickly. For those of you who were here last month, we talked about. For those of you who were here last month, we talked about the data release policies for the Commission data, and you all approved the our request to add a privacy board, which we need to do in regulations, so we haven't done that yet. At the same time, we want to move forward with our data sharing initiatives. And the first one on our agenda is to make the medical care database, which is our database of privately insured medical claims, available to Medicaid, which for their comparative analyses with Medicaid and private insurance. And they actually have a federal request right now to do a particular study, so it comes at a great time. The data would be housed at Hilltop, and we'd like to move forward with that. However, as we discussed last month, the Commission can only consider a request for data that has been reviewed by an institutional review board until the regulations are changed. Right now we have one recognized IRB that was recognized in 2011, and they do charge. And Medicaid is interested in getting the data and not interested in paying an IRB. And also we think we need to expand the number of IRBs in order to make this work smoothly until we have the privacy board in place. So we are here today asking you to recognize the DHMH Institutional Review Board. They are registered with the U.S. Department of Health and Human Services. Right now they're approved through 2018. They also have an approved federal-wide assurance, which enables DHMH to receive federal funding to support any research involving human subjects. And so if you have any questions, I'd be happy to answer them.
Any questions or comments?
Just a quick question. Does Medicaid share information with us?
Medicaid, yes. This is they have given us the MCO data, the Managed Care Organization data, which is what we consider to be the most parallel to the privately insured market data. And as part of an initiative, they had Hilltop do some crosswalking of the data, which they've given to us in our format, so it could be analyzed together. And they did the first 2 years under funding that we gave them, and they volunteered without any additional funding to do an additional year or two, which is really nice. So this is part of our fostering that data exchange. Thanks for asking.
Thank you. That's great to hear.
Brad?
Thank you, Linda. First of all, let me say that I know personally the individuals at DHMH that participate on the IRB, and they do so with great integrity and conviction.
Wonderful.
Situation's a little odd in that here you've got Medicaid wants to access data, commercial data, that's in the all-payer claims database. In order to do so, according to release that data to Hilltop, we need to have an IRB review it. We have an IRB, but they charge money. We don't want to pay it, and Medicaid doesn't pay it. So we have an alternative IRB that we want to approve, which is back at DHMH, which is the super agency that includes Medicaid, the request. So I know every step of the way you have vetted in terms of the registration process. But the optics are Medicaid wants an IRB, and so they're going to go to their own IRB because DHMH is Medicaid. So walk me through how that separation happens.
Okay. Well, I will say that later on this afternoon you're going to hear about the Patient-Centered Medical Home Initiative, for which we had to obtain Medicaid data. And in that instance, if you want to get Maryland Medicaid data, you have to go to the DHMH IRB. So they are sort of the designated IRB for Medicaid. And I realize what you're saying is it sounds like
commercial data.
It sounds like as though you're sort of going to the house that wants your information to get a release of that. But because of the assurances around an IRB, you know, as long as they're doing their job, they're independent. I see them as independent.
This is, yeah, just
but
for the record, there are
perception.
firewalls, so I think that this is,
Okay.
I think I need to ask you about those
Yes.
firewalls.
Yes. And so I think I do believe those firewalls are in place. We did investigate their certification and their arrangement and their management. Because we've dealt with them in the past, I know them to be very independent of what I think even Medicaid wants. You know, if Medicaid wanted us to get the data, but that's irrelevant to the IRB.
So in this case, DHMH IRB is protecting the interests, the confidentiality interests of commercial enrollees.
Yes,
and they will do so with the integrity that they bring forth in all their other IRB work. Okay.
Excellent. Thank you for answering what I should have said. Thank you.
Thanks.
Yeah, and I think that often the research organization that is receiving information, but more often conducting human subject research, will use its own IRB to conduct that review. So I think, and I have absolute confidence on the integrity of the DHMH IRB. We originally contemplated using them in its entirety. They worried about their workload on doing all of it. So I think this arrangement works fine. We will likely be bringing other proposals forward to use other established academic institution IRBs appropriately as we consider data release to those organizations.
Terrific. Are there questions or comments? If not, can I get a motion to approve the DHMH Institutional Review Board? I got a motion and a second. All in favor? Aye. Any opposed? Any abstentions on the phone? Dr. Peralta, are you for it?
Yes, I'm for.
Okay. Let the record reflect that. Thank you, Linda.
Thank you very much.
Moving on to agenda number 5, where a report on privately insured healthcare spending for 2013. The MHCC is required to report annually on healthcare spending and utilization, and Srinivas Radara is going to present the report. Srinivas.
Thank you. Thank you, Mr. Chairman, Commissioners. Pleasure to speak to you today. So just a quick background for you as to why we're here today, and this particular for the new commissioners. As you may know, the medical care database is Maryland's all-payer claims database. We house data that is member eligibility and claims data for professional services, institutional services, and pharmacy services. It is currently private insurance entities are required to report. That was life and health insurers and HMOs in the past, and more recently to close out some of the gaps in self-insured data, we've added TPAs and PBMs as well, third-party administrators and pharmacy benefit managers, and so that began in 2014. We are, in our enabling statute for this, also required to report annually on some healthcare spending and annual costs. So this is that report. In the past, there have been some more nuanced analyses, but it has become more of a monitoring report in recent times. And I would note that this year we're really, this is the last one that, in a sort of a prior generation, if you will, that it focused on 2013 data here. And so we expect in the future, as we have exchange plans and ACA policies taking shape in 2014, also the impact of the hospital waiver, et cetera, can all be studied in future years. So we've kept this to a brief sort of chart book style report, which you got as a draft, and we expect more in-depth analyses in the future. So as I mentioned, this is based on the 2013 data. We are not
2103. I apologize for that. 2013 data, and we have restricted this analysis to fully insured plans, and this is mostly because, as I mentioned, we haven't had the ability to collect data from pharmacy benefit managers. Rather, we've had the ability, but we didn't have a way to link it, and now we're developing the technology to link that data. So we wouldn't have been able to include pharmacy services, which, as you know, is a big component of healthcare spending, and so that's why it's focused on fully insured plans. And the study has focused on variation by geography, market segment, age, and service category. I'm going to focus on the market segment primarily today and some service category. There's one real major important difference in this report compared to the past reports. For those of you who've been tracking it in the past, we used to report on per capita expenditures. That is an annual measure of spending, total spending of the year. We've moved to per member per month, which is per member per month cost or spending, which is more consistent with the methodology used by the Maryland Insurance Administration and other studies of insurance, and so that'll help us sort of benchmark against external studies. And also, this is a way of allowing us to use more complete data. In the past, we were having to use a full year enrollees only to get a proper per capita expenditure. Now we're able to use part year enrollees as well, so it allows us to make better use of the data. So just a quick overview of the different market segments that we are talking about. There's the large private employers, what you would normally think of large group. In the past, the difference for a small group was 50 employees. As you know, under ACA, that moves up to 100. But in this study, it's the 50. And the definition is, at least nominally, the Maryland Small Group Reform definition for small group. We do know there are some inconsistencies in that reporting, but it should be representative of that. And then the individual market, and then is, as it sounds like, individual purchasers of insurance. And then finally is the MHIP, is the Maryland Health Insurance Plan, which is Maryland's high-risk group. As you'll see in the subsequent slides, they're a small component, but because of the nature of the people on that and the health issues, they cost more in essence. So this is to give you an idea of that. The green line going down is your member month. That's in millions as opposed to thousands for the bar chart. So that gives you an idea. The member month is really what's used in the calculations for PMPM. So this gives you a look at the change between 2012 and 2013. The numbers are per member per month total spending for the year for each market segment and overall. And the green line is showing you the percent, so that's the right side axis for that percent change. So this is fairly consistent with what we've seen in past years. It's about 2-3%. There is a higher increase in spending in the MHIP group. And as you will also see here, that as I mentioned, the MHIP segment costs more. They have more spending because they're sicker. There's the sicker population, and the individual market is a lower spending in part because they're younger and healthier as a group. So this is sort of to reflect that risk score that I mentioned. What is the risk of spending in each of these groups? And just as a helpful legend, if you will, for box and whisker plots for those who might need it. So the middle bar line is the median risk score, and the ends of the box, if you will, are the 25th and 75th percentile. Normally, you would have a minimum and maximum. The maximum in this case would have been very high, just because this risk score can go on to very high numbers, and so we truncated at the 90th percentile for this figure. So what you see here is essentially what you should glean from it, at least, is that the large group and small group are comparable populations. And you see something different, particularly in the MHIP group. They're a higher risk group. So I think you can see that readily, but there is a distribution. It shouldn't, it's easy to represent one number, and it's not that represents the entire population or that segment, and that there is variation within each group. But this should give you a rough idea of how they vary. So within the overall total PMPM that we described, this provides you a breakdown by different categories of service. That is professional services, inpatient and outpatient, labs, and prescription drugs. And you can see, depending on the different market segment, there's variation in how much of their spending is taken up by the different areas. And so to show you that a little more clearly, this gives you a percentage of their spending. So you knew obviously MHIP costs more, or large group and small group costs less, or individual in particular. But what you'll see here is, for example, the individual market, you have a much higher spending on professional services as opposed to MHIP, with all the chronic conditions and so forth. There's a higher spending on prescription drugs. So there are some variations as you look across each market and what they spend their money on and what healthcare utilization occurs. And finally, this just gives you a quick look at the out-of-pocket spending. This is, in our data, we ask for both what is the insurer reimbursing to the provider and what is paid out-of-pocket, like your co-pays or deductibles and so forth. So that's what this represents. You'll note, in particular, the individual market has a higher out-of-pocket expense, and that's because there's a higher proportion of CDHP, Consumer Director Health Plans, and other plans with high deductibles in that segment. So you have higher out-of-pocket spending. So that's your quick overview of the report, and I'd be happy to answer any questions if you have them.
Questions or comments?
I have a question. This is Peralta.
Yes?
Oh, hi. I would like to know for the MHIP group, and you're looking at, I'm looking right at the out-of-pocket and reimbursement share for that group of 84% of the 2013 total spending. If since you have that high 32% also for that category of prescription drugs, if much of that out-of-pocket expense is related to non-generic drugs, or the lack of availability of non-generic drugs for those individuals who seem to be sicker?
So that's a really good question. We have not looked for this particular market into the generic versus labeled drugs. We did look overall a year ago, and so we do see a growth in generic drug spending, and it could be that this particular population, because of their sort of specialty drugs, it's possible that they'd have to have more of the conventional drugs.
Right.
Yeah, that would be.
So, Dr. Peralta, this is Linda, and in last year's issue brief, there's a breakdown that looks at the prescription drug spending, and you're exactly right that generics are low in this population, or lower than a regular population, because the very high proportions of the prescriptions were for things to treat hepatitis C, antivirals, and HIV, and serious conditions for which there aren't really many generics. They have very high prescription drug spending. So, and we can send you a link to that issue brief.
Diane. Thank you. So just to confirm an assumption that I'm making, on the slides that refer to the total PMPM spending, this is reflecting spending based on what is covered. So in the individual market, there may be significant additional spending that it's just not covered under the benefit package. I'm just thinking, because this is 2013, as we start projecting forward and thinking about this report and what it may look like in 2014 and 2015, the relative difference in what the benefits are may make it look like there was some significant cost increase when it may have been simply things that are covered in now that weren't covered in 2013. Does that make sense?
Absolutely. Okay.
Just wanted to confirm that my assumptions, I was tracking with that. Thank you.
So, two questions. One easy, one a little harder. Is there anything in this data that's different than overall national trends, for either composition or trend that we should note?
Yeah, I mean, not dramatically. I mean, the recent spending projections from the National Health Expenditure Accounts pegged it closer to 6%, so this is a little lower than that. There was also a sort of nationally representative study done by the Healthcare Cost Institute, and with their data, they pegged it closer to 4.5%. And so this shows a little bit lower. I mean, compared to that, at least, where they did look at some out-of-pocket spending and so forth, we tend to be a little lower on several of those items. But the trends are comparable.
Okay. And then if you showed the one chart with the facility-based spending, are you able to break out professional services by place of service? So if we wanted to just know what percentage of costs were incurred in the facilities versus out of the facilities, you'd be able to do that?
Yes.
Could I? Is that a hard thing to do?
We can look into it and get back to you on that. Yeah.
All right.
Yeah.
That'd be great.
Sure.
Thanks.
Go ahead. One observation. I think it's important to look at spending in the MHIP population, the mix of services, as it may illustrate something that's maybe a little broader that may apply to the over 65 Medicare population too. And that is that typically in Medicare today, there's not a good way to capture the drug spending, and so your eye is riveted to institutional care in particular, which is a big cost driver. But when you actually look at not a similar, but a chronically ill population, which is what the 20,000 or so MHIP population is, you can see the very significant impact of drugs on the total spending bill. And I think when we start to move forward in monitoring the waiver with complete data, we're going to have to try to figure out what's happening on drug spending as well, because it may be a significant driver going forward, which we certainly have very limited abilities to control currently. I think, Linda, you hit it pretty much on the mark that the MHIP population is chronically ill people generally, which increasingly are moving out of using institutional care to ambulatory care, but large substitutions of drugs to keep them out of hospitals.
Terrific. All right, thank you very much. We'll move on to agenda item number 6, which is the Maryland Multi-Payer Program Evaluation. Let's see how many people we have. Okay, good. Jill Marsteller, Associate Director of the Center for Health Services and Outcomes Research at Johns Hopkins Bloomberg School of Public Health. Eileen Harris, the Principal Research Scientist and Managing Director at IMPAC International, and Guy D'Andrea, the Managing Partner at the CERN, will present the evaluation findings from the Maryland Multi-Payer Program. And joining them at the table is David Sharp and Melanie Cavaliere.
So good afternoon, Mr. Chairman, members of the Commission. Before we get started, I would like to do a little bit of level setting for folks in the room, around the table, and who might be watching us virtually about the patient-centered medical home. Essentially, the patient-centered medical home is a way of organizing primary care that emphasizes care coordination and communication to transform primary care into what patients want it to be. The patient-centered medical home is best described as a model of primary care that is patient-centered, comprehensive, team-based, coordinated, accessible, and focused on quality and safety. It has become a widely accepted model for how primary care should be organized and delivered throughout the healthcare system. It also encourages providers and care teams to meet patients where they are, from the simplest to the most complex conditions. The patient-centered medical home is a model for achieving primary care excellence so that care is received at the right place at the right time in the manner that best suits the patient's needs. The presentation you will hear this afternoon from the panel to my right focuses on the evaluation of the Maryland Multi-Payer Pilot. So with that, I'll turn it over to Melanie to start us off.
Okay. Good afternoon, everyone. So what we're going to go through today is an overview of the Maryland Multi-Payer Patient-Centered Medical Home, which we refer to as the MMPP. So we're going to go over some financial results that were derived by the program itself. We're going to go through an independent evaluation performed by the two ladies at the end of the table, and some upcoming initiatives and next steps. Okay. So in 2010, Maryland passed a law that required the Healthcare Commission to start a 3-year pilot that, again, is referred to as the MMPP. The big thing that this legislation enabled was the ability to offer incentive programs to practices, and also the ability for carriers to establish single carrier programs that tied incentive programs to the practices. So this program, the pilot, officially ended in June 30th of 2014. However, the program itself is continuing through the end of 2015. So in the program, there were 52 practices from the beginning. That includes 2 federally qualified health centers. They are all throughout Maryland, and they do vary in size and ownership. The next slide is actually a map that shows where they are in Maryland. They do include the primary care specialties, pediatric, family practice, internal medicine, and geriatric. They have about 340 providers. Most of those are physicians. There are many PAs and some certified registered nurse practitioners as well, including one nurse practitioner-led practice here in Maryland. There's about 100,000 commercial patients, 56,000 Medicaid patients, and about a quarter of those practices, they have at least 20% Medicaid patients in that mix. So here's the map that I was referring to, just so you can see we do cover all the state from western Maryland, southern Maryland, throughout the eastern shore. I'm now going to turn it over to Guy DeAndrea. He's going to talk about some of the financial results and the program itself.
Thanks, Melanie, and thanks, David, and thanks to the Commission for the chance to share some of the experience we've had over the last several years implementing the Patient-Centered Medical Home Program here in Maryland. As Melanie described, the legislation passed in 2010, and so from the end of that legislative session through the middle part of 2011, we worked to design a program for the Patient-Centered Medical Home here in Maryland that aligned numerous program operations and incentives to try to drive performance improvements for Maryland patients. The key elements of the design of the program were, first and foremost, innovative payment reforms to support primary care delivery. As I think we're all aware, primary care has been historically underfunded in the healthcare system relative to other components of the health system, and more importantly, relative to the value that primary care can create through better patient health care, better patient outcomes, better management. So the innovative payment model that we designed included both a fixed payment component that would support the investments that primary care practices were asked to make in order to improve care delivery, and it also included an incentive component that through which practices could earn additional financial incentives if they were actually able to drive better outcomes for their populations. I should point out that even the fixed payment component of the program did have performance requirements attached to it. Practices had to go through the NCQA recognition program to demonstrate that they had put in the capabilities to operate as a PCMH. The second major component of the program was multiple payer participation as specified in the 2010 authorizing legislation. And what that meant was that we were able to increase the signal strength to providers by having multiple health plans and multiple purchasers provide the same set of incentives and the same set of program requirements. In Maryland, that meant the large commercial health plans and the Medicaid program all followed the same set of rules for those practices that were participating in the MMPP. The state government convening role was very important in terms of getting all of these factors into place. We established standards for PCMH identification. Many more practices applied to be in the program than we were able to accommodate. Many of them didn't yet have NCQA recognition, but they all had made a commitment to team-based patient-centered care. We did seek geographic diversity and also diversity in terms of practice profiles, urban, suburban, rural, different numbers of physicians in the practice. And so in the 50 practices that Melanie described, and in the map you saw some of that diversity. the expectation of the PCMH program design was that practices would transform how they deliver care and how they interacted with patients to a more team-based environment. What that meant was that the actual members of the healthcare team were to take on new roles and new ways of working with each other, each of them practicing ideally to the top of their license, with the primary care physician really serving as the quarterback that would direct the overall patient care process, but also the inclusion of new team members. In particular, practices were required to invest a certain amount of their fixed payment in care coordination, focused especially on patients with chronic illness. The program included a technical assistance component so that through the Maryland Learning Collaborative based at the University of Maryland School of Medicine, practices received instruction and support in the transformation process. All of the practices in the program did successfully achieve the NCQA recognition, which was a key focus of the initial technical support. The program included common measurement of performance through both self-reported quality measures, more than 20 measures focused on chronic care management and preventive care, and then also through claims-based analysis of utilization, patient utilization, and cost. And then finally, throughout the term of this project, there's been a number of learning collaboratives convened by the Maryland, by the MLC, to help practices share best practices with each other, learn from each other, and continue to improve. So those are that's what we've been working on over the last several years. Next slide. So at the core of the initiative was a financial model where what we expected to see, what we hoped to see, was an increase in the volume of primary care services that were delivered to patients, perhaps even accompanied by an increase in, for example, prescription drug utilization, where more patients were getting the care they needed, were getting proactively managed, were being engaged in the care process. But then a reduction in preventable costs of care, for example, ER utilization and avoidable hospitalizations associated with chronic illness, so that the total cost of care would go down. And that reduction in the total cost of care could then be shared amongst various stakeholders in order to create a sustainable financial model for the program. And the way we saw that savings opportunity being shared was through the fixed payments, which I've already described, through the shared savings payments that practices could earn. And then some of that savings would be retained by the payers so that there was a financial benefit to them. I should mention that this model, at least in my view, is very similar to the financial model that underpins the Medicare waiver that Maryland has, right? That you have, that under global budgeting, you want hospitals to have an incentive to reduce their direct costs of care provision, and then that savings can be used to invest in community health programs, other interventions that help improve population health outcomes. So what we've seen, and the next couple slides talk about our experience here in Maryland. This is based more from the operational perspective, right? So we've been working to implement this program. We've been collecting data. We've been collecting quality measures from providers and analyzing that over the last several years just to support the operation of the program. And what we've seen is that the quality gains associated with the program have been real and significant. And when I say significant, I mean statistically significant. Over the 3 years that we've been collecting quality measures from practices, they've improved their ability to actually produce quality data, right, to tell us how they're doing. And they've also improved their performance by a weighted average across the entire population of about 15%. So that is a very important finding. And the financial incentives were key to getting that engagement, right? Those practices would not have been reporting that quality data to us unless there were some financial motivation for them to do so. But in reporting that data, in collecting that data, that motivated their improvement. In the final year of the program, their shared savings eligibility was also tied to that improvement, right? So over time, the program evolved to place greater financial emphasis on actual improvement and not simply meeting the administrative requirements of the program. I should repeat that in addition to the quality measure improvement we saw over the several years of the program, all of these practices did get through that NCQA recognition process, which affirmed that they had the capability to deliver patient-centered care. I don't think most of them would have gone through that process without financial incentives. That has been the experience around the country, that it really takes those financial incentives to engage primary care providers who are otherwise occupied with just running the day-to-day practice under more traditional fee-for-service payment models. So that's the quality side. On the financial side, and this for those commissioners who I've spoken to, or we've done presentations in the past, we know that the financial gains for the program have been harder to isolate. Over the course of the program, each year we've seen about roughly 40% of the practices achieve a shared savings payment, which is that they achieved enough savings to not only to pay for the fixed payments that they had already received up to that point, but then generate additional savings which they could share. Now 40% is consistent with what we see in some of the national experience. Only about 25% of the ACOs participating in the Medicare Shared Savings Program were able to achieve a shared savings payment in the first year. So, you know, these programs, I think, have a sound theoretical basis, but actually getting the results we want to achieve and then being able to measure those results is very difficult. There are a lot of different factors that impact overall cost of care in terms of the overall marketplace, the more broad economy, practice-specific changes that occur year to year. And certainly in this program, we found that is especially challenging for small practices. Right? So as the population size goes down, we see a lot more noise associated with variation year to year, which makes it harder for us to isolate what is real savings due to systemic improvement and what is due to just the natural year-to-year variation. So sort of trying to summarize our experience and thinking about the implications for how Maryland promotes advanced primary care going forward, one lesson I think we've learned is that providers do prefer to have consistent measures and requirements. Most of the practices in the state, of course, have multiple relationships with different health plans, where those health plans might be asking those practices to do different versions of the same thing. That creates, I think, friction for the practice and sometimes confusion, where the practice has to incur fixed costs to implement patient-centered care practices, but can only spread those fixed costs over a subset of its population that's not as financially as efficient as spreading those same costs over the entire practice population. So providers prefer consistency. At the same time, health plans and payers prefer to have a certain amount of autonomy and flexibility. They're trying to manage their business in the way that they see best. And so there's a natural tension there. And I think we certainly experienced that tension during the course of this project, and I'm sure it will be one that will a balance that is still necessary to strike going forward. That said, and it's true in Maryland as it's true elsewhere, the concepts that underpin patient-centered care are taking root and propagating throughout the healthcare system. I'm sure you're all familiar with the recent announcement from the Secretary of Health that their goal for the federal government is to have 50% of their total payments be value-oriented or value-based by 2018. In the private sector, we see a number of similar initiatives to essentially create risk for providers to deliver better value in the system. And everybody's trying to drive towards that value equation of higher quality and lower cost. So that certainly applies to primary care physicians, and that's been the focus of the MMPP. It also applies to specialist physicians in terms of how they work within the system to manage patient populations. It applies to hospitals, and in Maryland, very specifically to hospitals under the Medicare waiver. And then we're seeing a lot of activity around other allied health professionals and providers as they try to position themselves to be part of a value-based healthcare system and articulate how they can actually drive overall value. So I think those are the big issues that we'll continue to face in the next several years. So I think at this point we'll turn it over to talk about the program evaluation by impact.
Thank you. Thank you, Commissioners, for the opportunity to present our evaluation. I'm Eileen Harris. I'm from IMPACT, and we'll be presenting the overall external program evaluation along with my colleague Joe Marcella from Johns Hopkins University. So just to give you some background, this is an external evaluation that MHCC contracted with IMPACT to conduct this evaluation of the pilot. And our team includes, as I mentioned, IMPACT, Johns Hopkins, Bloomberg School of Public Health, Healthcare Resolution Services, which is a small business in Maryland, and the University of Maryland School of Pharmacy. So before I get into some of the results, I wanted to give a little bit of background on our approach so you could understand, how we approach this external evaluation. So this evaluation was quite comprehensive. It included both quantitative and qualitative approaches and consisted of a number of different methodologies. We did site visits. We actually conducted site visits and interviews to 9 MMPP practices to evaluate practice transformation that was mentioned before. We also conducted web-based surveys to evaluate provider satisfaction. We conducted a computer-assisted telephone surveys to evaluate patient experience and patient satisfaction. And then we conducted administrative data analysis using Medicaid data and the all-payer database to evaluate changes in quality, utilization, and cost. And we also used the administrative data analyses as well as the surveys to evaluate changes in healthcare disparities. So the provider survey and the administrative portions of the administrative data portions of the evaluation utilized 2 comparison groups in addition to the MMPP practices. We included comparison practices. One set of practices was a group of practices participating in another PCMH program in the state. And the other set of comparison practices were those practices that were, as far as we know, not exposed to a particular PCMH, but we call them less exposed PCMH. And these comparison practices were chosen to be as much like the MMPP practices as possible using propensity score matching, which is a statistical matching technique. And we matched the practices on practice characteristics and on provider characteristics within those practices and on characteristics of the practice location, such as like the median income of the location where the practice existed. So our goal there was to try, in addition to looking at the MMPP practices, to compare the changes over time from baseline or from pre-MMPP to MMPP, to compare those changes to practices that were not exposed to the MMPP, to see what of those changes could be attributed to the MMPP. This is called a difference in difference approach. It's a fairly robust approach to evaluation when you can't randomize the practices or the, in this case, practices to the intervention. So that's our overall approach. So to present all of the results, we developed an executive summary and 5-issue briefs that assess the impact of the pilot on those domains that I mentioned: healthcare disparities, healthcare quality, utilization, and cost, patient experience and satisfaction, practice transformation, and provider satisfaction. And we anticipate that these briefs will be released about the end of May. One other thing, because we had a little discussion about IRB, well, our evaluation was approved by 2 IRBs, the CHMH IRB as well as University of Maryland IRB. So I'm going to review the very high-level results of healthcare disparities and quality utilization and cost, and then I'll turn it over to Dr. Marcella, who will present the rest of the findings. So with regard to healthcare disparities, first of all, just to give you an overall approach, we assess healthcare disparities across 4 disparity domains: race, which was white versus non-white; gender, male, female; geographic location, which was defined as proximity to a large versus a small metropolitan area; and insurance type,
commercial versus Medicaid. And we looked at changes in disparities across our measures of quality and utilization from 2010, which was the baseline year pre-MMPP, to 2013, which was the year 3 of the program. So just to give you some very high-level findings, we looked at disparities, first of all, that were in existence in the baseline year, and there were 30 of them among our measures. So of those 30 healthcare disparities that existed in the baseline year, almost 2/3 of them improved, which is good. There were no change in 9 disparities, and 2 disparities worsened. So I imagine you want to know what were those 2 disparities that worsened, so I'll tell you. They were, the first one was the percent of young persons with asthma who had an asthma-related admission, and the disparity by location actually worsened, where large metro areas did worse. And the other one was the percent of patients with asthma-related inpatient stays. So it's a similar measure, so it's asthma-related. And the same disparity was a location disparity, with large metro areas doing worse. However, even though there were 2 disparities by location that worsened, actually disparities by practice location as well as race were the most likely types of disparities to be reduced by the MMPP. And they included disparities of inpatient stays and well-child visits. So, for example, the largest effect or impact on disparities was disparity of location for well-child visits, where the measure was whether the proportion of patients who had 2 well-child visits in the first 15 months of life. And in the practices in the large metro areas, they had a higher percentage of those of patients with well-child visits, but they declined over time. And the small metro area remained stable over time. So the difference between large metro and small metro got smaller, but it wasn't really to the benefit of either. But the disparity did, the gap got smaller. There was also improvements in disparities, as I mentioned, for inpatient stays, for focusing on stays that were ambulatory care sensitive condition related stays, those hospitalizations that were among patients who had ambulatory care sensitive conditions, which are considered to be treatable as an outpatient, and if they are treated appropriately should not result in a hospitalization. And we saw reduction in disparities by payer, location, and race. So we did see reduction in disparities there. Okay, so I'm going to move on to our evaluation of our measures of healthcare quality, utilization, and cost. So we developed a number of measures in these areas, and we just this brief describes the evaluation of the changes in those measures over time, and comparing those changes of the MMPP to the comparison practices. So as I mentioned, we matched each of the 52 MMPP sites to 2 comparison sites. And the measures that we developed were constructed from administrative claims data, all payer claims database, and Medicaid. And the measures were based upon accepted measures in the literature from a variety of different sources. So as far as the findings for this, one interesting thing to note, first of all, is that we saw differential effects on healthcare quality, utilization, and cost by payer. So we will be presenting the findings stratified by payer. So we present the findings separately for Medicaid and for commercially insured. And that we're not surprised at that, because the patients' populations are so different. The Medicaid population is younger and more likely to be female. So what we found, some of the highlights, are that we did see evidence that the MMPP pilot did slow the growth of some healthcare payments, specifically in inpatient, but also in outpatient payments. So overall, there may be some effect on reducing or slowing the growth of healthcare costs. So, for example, over the 3 years of the program, inpatient payments declined in the MMP in patients in the MMPP practices, while they remained stable in the comparison practices. But we only observed that in the Medicaid population. We did not see that in the commercially insured. We also observed that chronic disease management of some of the ambulatory care sensitive conditions improved. For example, diabetes management in adults and among the commercially insured, specifically looking at things like hemoglobin A1C monitoring. And we saw an improvement in asthma-related emergency department visits among Medicaid patients. We also saw a positive effect for adolescent well-child visits to the practices to which the patient was attributed among commercially insured. And we did see a few negative effects and negative impacts. For example, inpatient stays among Medicaid. However, keep in mind that we did see a positive impact for inpatient stays specifically related to ACSCs, but overall there was a negative impact for when you look at all inpatient stays together. So I'm going to turn it over to Dr. Marcella.
All right, thank you. So I think that what Eileen's talked about so far, is showing that that the program did have some improvements in disparities in particular, and it looks like there's some cost savings, and that we see some positive and negative effects with respect to Medicaid when you're comparing that group to commercial. So for patient experience and satisfaction, I'm going to talk about surveys that we did with them. These are the telephone surveys. We did them in 2013 and then again in 2014. There is no comparison group for the patient experience. It's just members of the MMPP program. There is one version of the survey for adults and a different version for kids, and you can imagine why that makes sense. But we asked them both about the delivery of health care, about their feelings of trust toward their providers, as well as their access and their chronic illness management. So those are the topic areas. It's not, okay? Okay, good. So the findings that we see in the patient surveys are, for example, at the end of the pilot period relative to the beginning, more of the adult patients rated their patient-provider communication highly than had done so in that earlier period. So that's one of the changes that we see. Most of the findings that we had or comparisons that we made were not particularly large changes over time, but this is one that actually reached statistical significance. There were some general trends in a positive direction, but they weren't really large improvements, and that's why we're not going to dwell on them. Respondents for children, in general, were very satisfied with their care for the kids. However, one of the lower scoring areas was access for kids. So that might be something for us to watch. It was hitting more 50% of people saying that access was excellent, as compared to more along the lines of 70 or 80% reporting good access for other measures. In general, when we roll patient responses up into a cultural competency scale, that's scoring very highly. So patients feel that their providers are culturally competent. Also scoring highly for adults was the access measure, not as good for kids. And then when we look at the surveys with respect to specific subgroups, so let's think about our chronically ill population, let's think about our African Americans versus Caucasians, we see that there are, generally speaking, some slightly lower scores for the chronically ill compared to non-chronically ill. And there tends to also be a little bit of a lower score with respect to trust and provider among African American adults and children, and advice on staying healthy improved in white respondents but got a little worse in African American respondents. So we are seeing a little bit of differentiation there. The chronically ill rated getting access to timely appointments a little bit worse than the non-chronically ill. And in the children, though, there were no chronic ill versus non-chronic ill effects between those two populations, chronically ill children, non-chronically ill children. So where we see sometimes that the chronically ill are scoring lower, in other measures we see them scoring a little higher than those who are not. And in particular, that's with respect to them being likely to report that their providers give them advice on staying healthy, for example, and they pay attention to their mental health. So those are positive in that group. And in the Medicaid population, we find them scoring higher than the chronically ill, both among adults and children, on two measures, essentially getting advice to take care of yourself and how they support you in terms of your ability to take care of yourself, and also in their other, advice, sorry, that's two items, advice on staying healthy, and then the other one is supporting you in taking care of yourself. Okay, so those are doing better. So that's it for patient satisfaction. So in general, it's pretty good, although there, we see some of the measures going in different directions. The practice transformation brief is going to inform you about the site visits that we did, where we interviewed up to 5 people working in 9 of the practices that were participating. Okay, and so this is a qualitative evaluation, which really means that it is our analysis of their responses. It's not, as easy as, I shouldn't say that. It's not the same as running statistics on numbers. Okay, I shouldn't say it's not as easy. They're both hard. They're both hard. Okay. So the findings show that the MMPP practice staff indicated that they felt that there were some important factors associated with practice transformation. Let me say that all of the people that we talked to felt that the PCMH had improved things in their practices, and they were generally very excited and happy about the PCMH program. They specifically cited that they felt that there was improved care coordination. They felt that their communication, both within their practice and with, in those large practices that have multiple sites, they felt that their communication across sites was also better. And they felt that they had advanced their ability to monitor and report on the patients that they're trying to take care of, and that they had reached better standardization of policies and procedures, and so that's what they felt was responsible for their success overall. So one of the things that is done in that brief is we looked at those who were the higher performers, just in that set of 9, based on NCQA recognition and also on their performance on shared savings. And those higher performers had a couple of consistent characteristics. One of them was that they had a practice champion who had been identified early, and 3 of them, who were the top performers out of 4, had a champion who'd been consistent throughout the entire program. So that makes sense. They also felt they had the right people to fill the PCMH roles, and that they had selected well in their new staff hires. They had already integrated EMR well into their practice. That was another predictor of that high performance. And then finally, they had the ability to review patient data prior to every visit so that they were ready to see that patient and ready with the information that they would need. It does not want to advance. It does not want to advance. Oh, there we go. Now it has decided to go with us. Okay, so the last brief that we're going to discuss is the provider satisfaction. The way that provider satisfaction was assessed was using a web-based survey. We invited all of the 339 providers who are part of the MMPP to respond. Then we had 2 comparison groups. So one, again, was that low exposure group. We figured they did not have a lot of experience with PCMH. And then there was another PCMH program that's operational in Maryland, and we included providers from those PCMHs as well. So what we found, what we asked them about was their satisfaction. Would you mind? Their satisfaction with care. Thank you. Their staff roles in care, job satisfaction, and kind of how is your care team functioning. Tell us a little bit about how you've composed your practice team. Who do you consider to be important members of your practice team? And then finally, what are your perceptions of the PCMH model? So keep in mind, we're asking that of people who have not participated in a PCMH model, those who are participating in the other PCMH model, and then, of course, the MMPP providers. So compared to the other practices, MMPP practices tended to feature greater inclusion on their teams. They were more likely to say, we always include medical assistants in our team. We always include health educators. They also tended to include social workers more, or had reduced them less over time compared to the other PCMH. In low exposure sites, they had increased their social workers, but not as much as the extent to which they were being included in MMPP practices. They tended to have high satisfaction with care within the MMPP program, and they had good perceptions of several of the team functioning measures that we asked them about. However, there were sometimes lower scores compared to the other PCMH with respect to some of the team functioning measures. Overall, we would have to say that with respect to how the providers responded, the program effects were kind of mixed relative to the change, mixed relative to the change that we saw in the non-MMPP practices. So when you say, how does the MMPP compare to these others, we're seeing that there really was not a lot of difference from the others, except that MMPP providers started kind of happier, more optimistic, and they stayed happier and more optimistic, while the other sites are kind of starting lower and actually improving a little bit over time, which is why we don't see a significant difference over time relative to that other group. Okay, but you can't say at the end of the game the MMPP providers are happier, still scoring happier than those in other programs. So the wrap-up of the evaluation, the findings of the evaluation show that the adoption of the PCMH model in the MMPP met several of the important program goals. And we think that the insights that we've gained here can be useful in evaluating other models of primary care delivery. I would say that our findings overall are pretty consistent with what we've seen in the literature. There are mixed effects showing up in the literature all over that are very similar to what we've seen in this particular MMPP program. So I would say that there actually ends up being, in my assessment, more good than neutral and more neutral than bad. There's very little that actually went south with this program in our estimation. And so typically speaking, you're seeing either improvements or neutral findings. Did you want to add anything? Eileen?
I just wanted to emphasize that I think, we believe that, as the second bullet says, that this is really an opportunity to, evaluate, to identify what works and what doesn't. And the other finding, overall that I think we want to focus on is that there were differences, for example, among, in this case, like Medicaid recipients versus commercially insured recipients. And so, it might not be one program fits all. And so we really need to think about how we can, design a program and improve a program so it can reach more patients and be beneficial to more. And I think this evaluation helps identify some of those factors.
So where do we go from here? Let me talk a little bit about next steps and upcoming initiatives. What we're looking at today are 52 practices that are participating in the MMPP. And with that program ending at the end of December, we want to work with these practices to help them transition to existing single carrier programs. Today, CareFirst and Cigna have MAPC recognized programs staff has been working with United Healthcare and Aetna to help them develop and launch their programs here in Maryland for probably about 6 months now, and it is our hope that we can bring their applications to you all for approval sometime over the next couple of months. So it could be later this summer, ideally. So that's the major initiative with the practices, to create a glide path to allow them to go into some other program as opposed to just reaching the end and not knowing where to turn next.
So some of you have participated on our PCMH transformation work group. We did convene it beginning in last February. We met several times throughout the fall. So we will be starting those back up and continuing them through the summer. What we'll be focusing on is how to measure quality performance, the ability to attribute patients to practice, ensuring payment transparency to the practice, supporting care coordination, qualifying a primary care practice as a participant. So, is NCQA correct, or are there other requirements that we should be looking at, and continuing to reduce disparities in the delivery of health care. So those would be the focuses of the work group.
And before we get to questions, I think just to sort of summarize next steps, where we're headed for it is a smooth glide path for practices, continuing the MMPP through the end of the year, and then helping these practices transition to something else, and then working with the commission as well as other stakeholders around how we continue to promote advanced care delivery models throughout Maryland. So with that, we look forward to your questions, the evaluators, staff, regarding the presentation this afternoon.
Thank you, David and team. Since we have a work group after the formal commission meeting to get into some brainstorming, I suggest that we focus around the evaluation here, this discussion here, and let's open it up.
A question, and you did a great job summarizing a tremendous amount of work, and so I applaud that, and a bit of a huge effort. I had an aha moment when you were going over the data around access, and then the correlation with the reduced use of inpatient outpatient services. And I didn't know whether there was the capacity to be able to look at, it's going to be complex, the dose of multi-payer features or access, improved access that may or that may have improved and contributed to the reduced use of ERs or inpatient and outpatient services. So I think dose is a whole other conversation, because I know that's very hard to get at, so maybe stay with that second part.
So most of the access measures we have are from the perspective of the patient. So the patient's telling us how, whether they felt they had adequate access. Whereas the other data that you're citing are from the claims analysis. So that doesn't mean we can't put them together. We can put them together and try to analyze the extent to see we see a correlation there. But I think that's a great observation. I think the other thing that we didn't talk about that much, but that is also consistent across many of the different pieces of the evaluation that we told you about, is the continuing reference to better care coordination. We're finding that from the interviews that we did. They talk about better care coordination. We also saw that there were potentially some signs of that in the fact that the ambulatory care sensitive conditions, which are the ones that are preventable, right, we're supposed to be able to keep them out of the hospital. And so we're starting to see better performance on those ACSCs. And so that may be due to that care coordination aspect as well. Those are consistent findings that are also in keeping with what you've cited.
Thank you.
Questions? Adam?
So thank you. Yes, excellent. Was there any data suggesting that the patients who are the hardest to deal with improved in these practices, or did you see any provider discussion about that issue? It seems like the potentially, at least financially, lowest hanging fruit in this are the patients that are the least engaged. And what did you guys find out about those folks?
and/or their providers.
Right, the least engaged. So they probably did not answer our survey.
Correct.
I'm guessing. We can certainly talk a little bit about the chronically ill. They are they need care. They need attention. We did use an instrument called the Patient Assessment of Chronic Illness Care to ask them what they thought about their care, and those scores stayed pretty high and consistent across the time period from the beginning to the end. One area where they were a little bit lower was in follow-up and coordination. So the chronically ill are giving us the feedback that follow-up and coordination could improve. It was the lower scoring item from that instrument. In general, though, they are saying that with the exception of getting timely access to appointments, they are generally speaking a little as happy as non-chronically ill individuals. And in fact, in a couple of items, they're happier. So for that particular sticky wicket, I think we have a little bit of information. Those ones that are not participating in care and are not coming in for visits and that kind of thing, we're not going to have a lot of data on that group. Do you have other thoughts on that, Eileen?
Well, I'm just thinking about the administrative claim side of it. When we stratified by Medicaid versus commercial, so if you sort of use that as a proxy for, sicker patients, which is not, not perfect. We do see some, it seems like the commercially insured had more positive effects. There were more positive effects among commercially insured than there were among Medicaid. So there might be some indication they were harder to impact.
And then Bob?
Question about the cost findings in the evaluation, and appreciate the multiple perspectives with which you looked at this program. On slide 17, where references, I loved the model on slide 9, and I was aching to see that model turned into just a simple summary of the numbers that you found in the cost evaluation. And I realize it's often not that simple. But could you describe, thinking about that model? Overall, was there a reduction in cost? Overall, was there? Because in the positive, neutral, and only a small negative impact, to me, to really be able to understand that, I want to think of that in terms of the overall impact on cost of care.
Well, I'm not surprised that that question's being asked because that's what we like. That's really what we want to know, right? Our claims-based evaluation was a practice-level evaluation. So the data that we analyzed was aggregated at the practice level. And as I think you had in one of your slides, it's really hard to isolate that financial impact. Our evaluation wasn't specifically designed to do like a cost-benefit analysis or a cost-effectiveness analysis. That would take a different type of analysis. It's doable, but it's not something that we were able to do with the data that we had. So what we found was, yes, there seemed to be, when you compare the MMPP practices to the non-MMPP practices, there was a reduction in some areas of cost. But overall, when we looked, we had one measure that was overall cost. There was no difference, between the two practices, between the two MMPP versus non-MMPP. But that doesn't necessarily mean that there wasn't a cost savings or there wasn't a cost benefit.
So I just was going to share a little bit more about some of the findings we had from looking at the operational data. So as part of the process, we looked at utilization data, including hospitalization utilization, and then we looked at cost. And we did correlate those two sets of data. And there is a positive correlation in the sense that lower hospital utilization is associated with lower total cost. Right? So that's the relationship that's illustrated on slide 9. What we didn't see was a consistent ability of all the practices to drive down that utilization and therefore reduce the cost. And the R-squared on that correlation was around 0.25, I think, somewhere in there, which is not really high, but it's not real low either when you consider all the variables that influence total cost of care. So we did see that relationship. I don't think we weren't able to fully translate that through to make sure that all the practices achieve that outcome.
Yeah, congratulations on an impressive research effort. I'd just like a couple of clarifications. In your discussion of the participation of the patients, you refer to 100,000 patients commercially attributed to the program, and then about 56,000 Medicaid patients. When you say attributed, I don't know exactly what that means. Did the patients know, for example, when they were involved in this program, that they were enrolled in this evaluation? Did they know that?
So the program design included a notification to the patients that their practice was a patient-centered medical home, and they had the ability to opt out.
Oh, okay.
Now, the real way to opt out would be to switch practices. But if they opted out, then they weren't eligible to get the fixed payments and other financial incentives to the practice.
Okay. So they knew then, right away,
they knew
that they were involved in this program. Okay.
And for purposes of the various calculations that we did, patients were attributed to practices based on claims history and looking for those practices that delivered the preponderance of primary care services to any individual patient.
Okay, thank you very much.
Other questions or comments? Ben?
So for those people who want more quantitative results, you're going to see some of those in the issue briefs that are coming out on May 10th. And we do plan to get an appendix of even more detail that folks can delve into. I think this has been very helpful at a high level, but I think there will be a number of commissioners who want to look at some numbers. I think the only thing I would add is that I think this evaluation seems generally in line with what's been reported nationally across a range of PCMH programs. And keep in mind that the definitional construct of what a PCMH program is has quite a bit of variation. But most recently, the CMS has released tomes of evaluation results from their first PCMH evaluation, the Medicare multi-payer MA MAPC program, and the more recent one, the Comprehensive Primary Care Initiative. The Comprehensive Primary Care Initiative was actually somewhat modeled after the Maryland program. It's also important to note that although we had a very inclusive private and Medicare participation, we never had Medicare. We had Medicaid and private, and one of the staff's to do is to sort of look at, was there spillover effect on the Medicare population? I don't know if we'll have resources to do that in a timely manner, but we do have a lot of curiosity. A patient-centered medical home under NCQA requirements says we'll treat all of your patients, all of our patients in the same manner. So we would hypothesize that there would be some benefit. We'll just have to find some resources to do it. It's beyond the scope of the evaluation.
Maybe just one final question. And this is a little bit more speculation or just trying to discern what you can from the qualitative and quantitative data. But, under the waiver, we're supposed to, over time, adhere to a global budget. And so, getting total cost of care down and affordability is really critical. So based on what we know from this or from the national work, what would we do different in advanced primary care to actually have a material impact on the total cost of care?
More of the same. I mean, we need to, I think if it were applying to, more of the patients, we were actually monitoring the care. I mean, as Ben observed, we weren't looking at the Medicare population at all. And the Medicare population are the ones that are using expensive hospitalizations and so on a lot, not their own fault, of course. And so the extent to which we can expand some of the things that we monitored here to that additional population, you might see more evidence of movement more broadly in cost.
And just to follow up on the chairman's point and what Jill was mentioning, that's exactly what the literature has been reporting. So at the conclusion of all these analyses, they continue to urge more work in this domain and continue to suggest more time to really be able to tangibly identify those results better.
Yeah, I might suggest something slightly different, that oftentimes we're presuming that what happens at the front line is exactly the same in all these models. And because they're very people-driven, they ultimately are going to be different. Let's just be clear. Some people are better at care coordination than others. But we kind of treat it all as one. And I think getting a better insight into what drives excellence and just getting into like the individual component of it is really important, because I think if you put 100 care coordinators and 25 of them are really good, 25 of them are bad, and 50 are in the middle, you probably get the same data that you're getting right now. And it's not whether you have a care coordinator, it's whether there's somebody who's really good, and how do you actually measure what's really good, and is NCQA doing the right job of it or not. I mean, those are some interesting ways to maybe go further into it than just the measurement of are we doing care coordination.
So I think that when you open up that issue of care coordination, you really open up a hornet's nest of different perspectives on and what works. For the commissioners that weren't here from the start, the care coordination function was embedded in the practice itself, unlike, for example, the care, typically under the Care First model, care coordinators are provided by the payer. So what we didn't do as much work as we would like to, our practice transformation team, which was largely composed of faculty members from the School of Medicine and the School of Nursing at the University of Maryland, did a bit of work in looking at the sort of mix of what those care coordinators were doing, the capabilities of those care coordinators, and the training and linkage they had to the practice. And although we had embedded care coordinators, what we definitely know is that the academic expertise varied significantly. How they integrated with the practice varied significantly, and how they interacted with patients was also different depending on practice size, practice affiliation, et cetera.
I really appreciate your question about what did we learn and what could really impact costs going forward, particularly thinking about this pilot program winding down at the end of 2015. And it struck me, I can avoid this question, but I got to ask, and thinking about that transition back to the single carrier advanced care delivery models, understanding the features that the evaluation highlights as being particularly effective, whether it's the aligned measures or it's the care coordination or other aspects such as that, I think will be incredibly important to put front and center if we don't have the option of continuing, as you're describing. And maybe I'm reading too much into that, but the slide several times referenced this winding down at the end of 2015. If there is a transition to backwards, sorry, that's kind of how I look at it, but if there is a transition that moves back to each carrier doing their own thing, the insights from the evaluation will be incredibly important to guide that transition.
Thank you. Okay, thank you very much. Move on to agenda item number 7, which is the Maryland Healthcare Quality Report. Tressa Lee is going to provide an update regarding the Maryland Healthcare Quality Reports website that's going to focus on 3 main areas: top 25 medical conditions and charges, healthcare-associated infections data, and the health benefit plan guide. Tressa?
Do that every time. Our new Healthcare Quality Reports website. What we'd like to do today is just to give a demonstration of some of the changes that we've added. But before I do that, before Eileen actually does that,
Let me introduce to my left. Here is Evanson Makura. He actually focuses on our CLABSI data and other HAI data. And Eileen Witherspoon, she also focuses on HAI data and is responsible for the CDIF. So for the benefit of our new commissioners, let me just give a little background on this project. This website actually is it's a website that we released for the first time officially in December of 2014. It really represents the repurposing of our hospital inpatient, our hospital performance evaluation system. We actually use this website for communication with hospitals and for submission of quality data. It's been repurposed and expanded to create a more comprehensive website that includes not only hospital information, but information on long-term care, linking to our long-term care guide, the opportunity to add physician information eventually. We now include our health plan quality report, and we also link to our ambulatory surgery guide. This new website is designed to really reach consumers. It is designed at a 6th to 8th grade level in terms of our communication. It has new features and functionality not previously available on their hospital website. It also incorporates free software from ARC, my own network. Monarch is the acronym for this free software. It will be updated. It's in the process of being updated, and we're looking forward to using that in the upcoming versions of this website. As I mentioned earlier, we are expanding to include the health plan information, converting PDF reports to web-based display. So right now we have a series of PDF reports that provide information on health plan quality and performance. We will be transitioning that to this website. This month we're transitioning the consumer edition of those reports, which include the member experience information. In October, we'll come back with the full transition from all the reports to web-based displays. I'd just like to mention before I turn it over to Eileen for this demonstration that this project really is a team effort and includes more than just the technical. It also includes some of the major changes to procurement that we are currently moving forward. There are 3 contracts that support the health plan report. One is a report development contract, which we believe we'll be able to eliminate not this year, but next year. There will be significant savings associated with that. We actually appeared before the Board of Public Works yesterday, and I'd like to acknowledge Bruce Kozlowski, Charmaine Robinson, Andrea Allen, Siobhan Madison, and others who prepared a very clearly defined and concise justification for an extension of one of the contracts that will allow us to do the website work this year as well as have a parallel report for the open enrollment period that begins in October. If there are no questions concerning that, I will turn it over to Eileen, who will just will highlight some of the changes that have been incorporated into the website since we last spoke.
Thanks, Teresa. So first, I wanted to show you the area where we added the consumer focus group report. It's under Who Are We? Project Philosophy. And take a second here. So now the focus group reports are available if anyone is interested in reading those. Now I'll move on to the health plan guide. So this is the landing page where you still have access to the PDF reports, the comprehensive quality report and the consumer edition of those reports. And then as Teresa mentioned, we added the consumer rating, so I'll click on that for you. So this is another landing page with the different topics you can pick from. I was going to show you what satisfaction overall looks like just to give you an idea of what the tables will look like with the data. So MHCC uses the results of a national survey to find out how satisfied consumers are with their health plan. This table is similar in layout to the rest of the site with the ability to compare several plan types as well as to sort by question and find out more information about each plan. We're also going to get rid of the decimal points on these, but as you can see, there's star ratings, and this is taken directly from the consumer edition of the report. Are there any questions on this section? Okay. Then I'll move back to the hospital guide to update the infections data and the charges. So we'll start with Clostridium difficile infections. This is the first year that we are reporting this data. C. diff, or Clostridium difficile, is a bacterial infection that can cause potentially deadly diarrhea. People who recently took antibiotics are at higher risk of getting sick with C. diff, and this can be spread in healthcare settings. So the reporting requirements for this include all positive lab results for C. diff in all inpatient locations except for baby locations. But we are only reporting on hospital onset cases. So let me show you what data is available here. If you click on this arrow. So it's similar to the other HAI information, where it shows the number of infections, the number of patient days, and then the SIR calculations that compare the hospital to the national baseline. And this table has the same features and functionality as seen in other areas of the guide, where you're able to sort by hospital name or hospital performance, and also compare up to 5 hospitals. So for calendar year 2014, 6 hospitals did better than expected. Unfortunately, 17 hospitals did worse, and Maryland as a whole did worse than expected compared to the baseline for this first year. We were 18% higher than expected on number of infections. I wanted to mention a couple of points from the most recent CDC HAI progress report, which was released in January of this year. Maryland is only one of 20 states with a C. diff reporting mandate, and we're only one of 23 states that are validating the data, so that could possibly be impacting the rates we're seeing here. But only 2 states are doing worse than Maryland, so we recognize this is an issue. We're currently in the process of validating the data, and we're looking to collaborate with other stakeholders to address this in Maryland. The QIO, QIN, VHQC has an initiative right now that is looking to reduce HAIs, and that includes C. diff. One of the aspects of that initiative is implementing a comprehensive antimicrobial stewardship program, and our understanding is also that the department is working with hospitals to reduce C. diff with implementing antimicrobial stewardship programs as well. And lastly, CDC has a newly available TAP report, which stands for Targeted Assessment for Prevention, and these reports identify facilities or units that have the highest excess number of infections. So we're looking to use those to see which hospitals or units need interventions. So are there any questions about CDI before I move on?
So the majority of states do not validate their data. Is that what I heard you say?
Yes, that's what the CDC
and so that data is included in the performance data to which we are held, right? Yes. So, okay, that's an important. Is that noted somewhere in the? I'm kind of reading here. But that's important.
Yeah.
I mean, I'm not saying that would fundamentally change the findings, but it could. So.
Right. Remember, we found the same thing occurred with the CLABSI data. Exactly.
Right. So when the data changed markedly when it got validated.
Yes.
So I'm passionate about stewardship, and I don't really know what's happened, but there's been some developments, CDC guidance on hospital protocols. Mm-hmm. So what is the department doing as far as advancing that with the Hospital Association or others, or maybe?
Yeah, I think Ebola sort of redirected a lot of the efforts with, yeah. But I spoke with Dr. Cosgrove recently, and she's going to reach out to Lucy Wilson to try to move that forward.
Okay, we'll come back to that. Yeah, thank you.
Okay. I'll move on to more positive news with CLABSI. Do they have the? So there's a colorful handout that was provided. If you want to take a look.
In front of you.
So there has been consistent improvement across the years. However, if you look at the handout you have, it appears to have leveled off in the past 2 years. There's also hospital-specific information in that handout comparing 2010 to 2014. And now to the actual data for 2014. 7 hospitals, as well as the state overall, are doing better than the national baseline. 17 hospitals had 0 infections, which was the same as last year, and no hospitals are doing worse. So Maryland did 50% better than expected. I did want to mention, though, starting next year, CDC will be updating the baseline for the SIR calculations for the HAIs to 2015. So that's going to affect probably negatively all of the hospital performance. So that's just something to keep in mind. Are there any questions about CLABSI? If not, I can move on to the charge.
Sorry, if a number of these hospitals have 0 and you update the baseline, how can you do better than 0?
No, you're right.
Okay.
I mean, a lot of them, since they're smaller hospitals, they're not statistically significantly different, so they fall into the same category anyways. But no, you're right. There has been some talk on some of the calls we're on that some of the states are not happy about that, that even the hospitals that are doing well are going to look bad now if they're compared just to last year versus, you know, I think CLABSI is 2006 to 2008, so that was 7 years ago. So I think all the states are kind of in the same boat.
And we believe the hospital will continue to perform well. It's just the comparison will be so different that.
Okay. Now this is the top 25 medical conditions and charges, and it provides the top 25 medical conditions treated by hospitals. It includes the number of cases, the average charge per case, average charge per day, and the average length of stay. So it has been updated with calendar year 2014 data. The medical conditions have remained fairly consistent between the 2 years. There have been some change in the number of where the rankings of where the conditions are, but I think there was only one change for that year. But we did want to show you there's wide variation across the facilities in terms of charges for these conditions. For example, on knee joint replacement, if you sort by average charge per case, did it go? Let's see, it takes a second here, but I believe it was going from 17,000 to, oh, it's spinning, to, was it 50 or 60,000? Yeah. So there is wide variation across the hospitals. So we are looking to improve this section by presenting the data in more meaningful ways, like providing charge information for common elective procedures and also expanding to the top 50 conditions versus where we are right now at 25. Does anyone have any questions and concerns with the charge data?
And just a reminder, we are presenting the charge data this way because it was the approach taken by HSCRC. This was a component of the website that HSCRC was responsible for. So we moved over that approach, and then we want to enhance and modify it going forward.
So if a consumer or an interested party is on site, how easy is it for them to click a link to ask you questions?
So there is a Contact Us button at the very front. Let me see. There's also Contact Us for, although, here we go, Contact Us. And then they can email us.
That'd be great to kind of figure, because I think as you get into usable data, people when they're on that will want to have questions, and so just making it as easy as possible for people to clarify things I think would be helpful. If you have to navigate 4 screens back,
right,
that's going to be a barrier.
Right. And we have, since the development of this website, utilized focus groups, consumer focus groups, and we have others planned going forward so that we can continue to engage consumers. But you're right, I think that would be a really good enhancement to allow persons to ask questions or access us fairly quickly.
Andy?
Yeah, thank you for that. Just interesting. Are there disclaimers there that show that these charges per case have nothing to do with the hospital? The hospital doesn't set their charges per case; they're set by the state, and that they change from minute to minute. Practically, I mean, you have to keep them under a cap at the end of the year. So the only way to do that, since your volume varies and other things vary, is for the state to change them minute to minute.
Right.
Maybe not minute to minute, but certainly month to month. There could be wide variations within a single hospital in the charge per case over the course of a very short period of time
It has nothing to do with any change in the way the care was delivered, and is completely outside the control of the hospital, therefore.
Yeah, that's a little tricky, and it is within the control of the hospital a bit, because the state doesn't tell the hospital to charge that amount for that procedure. There's some flexibility that hospitals have in terms of pricing for these services.
What flexibility? There's no...
Because the rates that are established for hospitals are unit-based rates. So hospitals do have some degree of flexibility in determining what they'll charge for given procedures. It's not like a procedure-based amount that is set for hospitals by, and I assume you're talking about the HSCRC.
Yes.
Right.
Yes.
Yeah, and that's where it gets really technical and tricky to express that to the public.
It just doesn't have the same meaning that it does in other states or other countries or any place else where you have competition. When you say normally when you engage in a contract with somebody and you tell them how much you're going to charge them for something, and you can tell them because you said it. And in the state of Maryland, that's just not true. I mean, the rate commission defines the rules around what you're allowed to charge.
But I mean, I think that if I could, I mean, I think that we recognize that as we move, as this commission focuses more and more on price transparency, we'll have to work, closely with the HSCRC on this, because I do think that even from a standpoint of a hospital, there's not a lot of understanding at why, and I've tested this hypothesis with one subject recently, a hospital CEO, on why are your costs for this APR DRG much higher than your neighbor down the road. There's not a lot of understanding of this, and I think you're right that there is HSCRC approves the cost structure that the hospital presents, but I don't think they prohibit someone from charging less than they would like to. And I think these types of tools, as we start to roll them out and make them more meaningful, will be helpful not only for consumers, and frankly, and Bob remembers this, and I'll use the same quote, is that people probably are never going to shop for healthcare services like they shop for shoes. But I think this transparency does help, but it also helps the healthcare providers. And I know that within some systems there's beginning to be some discussion in large systems, like for a device, are we all buying the same the same stent across our system, and that type of shopping that could be aligned more consistently, that may be driving variation, hasn't really occurred. So I see this price transparency initiative as being helpful for healthcare providers as well. Maybe within their own system they don't understand why our costs are higher, why our costs are moderate relative to others. I think it's going to be pretty useful.
Well, across the 14 hospital system, I can look at variations in cost on knee replacement and understand where they're coming from. And we can do lots of things to standardize our costs per case and our practices per case, but our charges per case are wildly variable, and we can't control those. They're based on fixed cost infrastructure within the institution, and we can't move that around and charge it in other ways. So that's not true.
Well, not only charge in other ways, but I think it would be good. HSCRC is coming here next month, correct? For another
not on that subject.
No, not on that subject, but maybe at some point we could have them speak to that specifically, so that it's whatever the restrictions and whatever the flexibility hospitals have, if they could just speak to that piece, I think it might be helpful.
Let me clarify one fact, though. So this is available today for the public, or is this?
Oh, yes.
Okay, and so is there any page that is giving any contextual information on the pricing environment in Maryland compared to other states?
No, we don't do that.
Okay, so I would suggest that I think it's critical in the state, given the uniqueness of it, that we at least educate the consumers now how to position that, and what the right way to position that is going to be, I think, subject to a lot of debate and input. But I think I think I'll put out there a strong suggestion that having some context is better than no context.
Right. And actually, when you see the 4 sliders we have on the front page, we have one for healthcare costs, which is where we thought over time we could develop a little bit more on the HSCRC and the role. You'll see it talks a little bit about the waiver and HSCRC, but you're absolutely right, is that there needs to be a place where we explain the uniqueness of Maryland and how it impacts charges, what hospitals are limited to do versus whether they have any flexibility at all.
Okay,
and
so
how
you do have some context that we could then react to further. Okay.
Yeah.
So along those lines, particularly drawing on the uniqueness of Maryland, hospital charge data that's made available is actually presented in states all across the country, and there are a variety of reasons why people push back on it, whether it's the insurance contract saying that's not really what people pay. But one thing consistently in other states, and I believe it would still happen in Maryland as well, from a consumer standpoint, to be able to see that the charges are different, that the cost structures are different, hospital to hospital, where we may all assume that that's a given and people understand that, and that isn't necessarily understood. So even if it's at that high level, there is value in I believe there's value in sharing that comparative charge data. And particularly if somebody's not insured, they're paying out of pocket, that's something that is of intense interest, or if they've got a high deductible plan. So related to the uniqueness of Maryland, one of the most prominent comparison websites, this is excellent, and as you know, I've been a long proponent, and I'm very, very pleased to see what we've got going in Maryland. One of the most prominent comparison websites across the country, particularly used by businesses large and small, is the Leapfrog group. And because Maryland is unique, and we do not, as a state, submit our data to CMS for the inpatient prospective payment system, Maryland is the only state in the country that the Leapfrog group does not report on, because we don't, my understanding is we don't submit that information to CMS, so therefore measures aren't calculated in a way and made available for the Leapfrog group to use. I would really appreciate some consideration from our team here to see if we could, I believe it's only about a dozen measures, if we could calculate those measures to make sure that going forward, Maryland is not called out as the only state in the country for which the patient safety scores are not available, particularly knowing that we're a small state, relatively speaking, and people cross, and they need to understand, you know, if we've got folks in D.C. who want to come up to Hopkins or come up to the University of Maryland, and they're interested in the patient safety scores, and there's nothing there because of our unique situation. Anyway, I just put that out there because I'd really appreciate knowing more about what we can do to make sure that Maryland is included in the Leapfrog patient safety reporting going forward.
I did speak with representatives from Leapfrog, and I spoke with MHA representatives to see if they would be interested in supporting a push to get Maryland hospitals to participate in Leapfrog. And the preliminary response was they don't endorse any particular measure set, but that they would be willing to work with us perhaps to say, let's have a webinar on what Leapfrog is, what it does, to try to get that additional exposure to see if the climate's a bit different for hospitals to participate.
Actually, I'm talking about something different. The Leapfrog surveys are voluntary all across the country. So in that sense, Maryland is no different than any other state where hospitals may step forward voluntarily and participate, and others may hesitate. And there are, I believe, a handful of Maryland hospitals that are choosing to participate. So that's not the issue. The issue is the data that we sit on, that other states submit to CMS, and CMS calculates measures. I've been told that Leapfrog does not have access to those measures from Maryland and would really appreciate it. So I'd really like to know more about that.
So, I mean, the measures that I think you're referring to are those that have been constructed from Medicare, by Medicare. But historically, you're absolutely right that Maryland, because they weren't reporting on those measures, they couldn't be reported by CMS because Maryland had its own quality reporting initiative, and therefore we didn't align. But beginning Last year, everyone agreed to do that. I'm not sure why that has. CMS should have the Maryland data just as they have the data for other states. It's really not a state choice, except in the predecessor system, Maryland had at least carved out measure. I mean, we had a sweet, Dr. Pollack aside, I think the old payment model was a very sweet deal for Maryland, and what has happened recently has been it's been a much more aggressive deal. But as part of that, the state agreed basically to align, or agreed on behalf of its hospitals to align on quality reporting that was required by all Medicare hospitals. And in addition, we continued to have some additional measures that we would use to monitor Maryland hospitals ourselves. I think I have that pretty much right, because the previous health secretary did sign an agreement saying we will agree to report to require our hospitals to report to CMS on these measures. Is that correct?
Right. We require now hospitals, Maryland hospitals, to report all metrics, inpatient and outpatient, that are part of value-based purchasing, or the inpatient quality reporting program, or the outpatient quality reporting program. So those measures are submitted to CMS. That data, rather, is submitted to CMS, because we don't get that. That was part of the streamlining process. So there may be just some communication between the two of us in terms of which data sets we're talking about, but it also may be that CMS has the data, and there may be some box that the hospital has to check to say, yes, you can release my data to whomever asked for it. So it's just getting through those technicalities, I think, that might resolve some of this.
So to make sure I understand, so Maryland's on board. I'm hearing you say that we're fine with sharing whatever measure results or data that's needed in order for Maryland to be included in the inpatient prospective payment system with CMS, because that's where that.
What I'm saying is that our hospitals, Maryland hospitals, submit that data to CMS now as of January 14th.
Right. So it might be a time lag or something like that.
Right.
Yeah. Okay. Okay. That helps.
It's really not at other states. Other states are not electing to do this, and Maryland is not. It's simply that those other states are part of IPPS and OPPS, and as a function of being in that system, those hospitals have to report. And previously, Maryland had this very generous waiver program that exempted us from the payment system, and also exempted us largely from other quality reporting initiatives, because we had our own. As a result of the agreement signed in 2014, those exemptions on quality reporting have gone away, that we have to, Maryland hospitals have to now submit that same information.
So from what I hear, it sounds like it's both A, highly solvable, and B, hasn't happened yet. So maybe we could just do a little bit of offline work, and then see if we could tie in where the final barrier is, and see if we could check that box. That would be great. Other comments? So I just want to make a comment that every time you show the web, it keeps looking more consumer friendly. So I just really appreciate what you're doing.
Well, thank you. Thank you. Thank you.
Yeah, I think that we're really anxious. I think Dr. Pollack's point we'll like to pursue and provide some, maybe there are other people other commissioners that want to understand that a little better. But unless we hear differently, our focus is to make more charge information available. And if we need to nuance it in ways that the Commission thinks are appropriate, we'll be very happy to do that. But I think this is a movement that's really sweeping the country, and we don't want to have Maryland get an F on price transparency.
Yeah, I just want to, if it's price transparency, it has to be. So you have to be transparent about where the prices come from, and completely transparent about the methodology as well. And not attempt to hide that from the public in any way.
Absolutely.
And I should just add, on every, not every, but the hospital websites that I've reviewed and looked at, they have that statement that these charges are required. We must charge these prices in accordance with HSCRC. So it's there on their website. We don't have that same statement here.
On that point, on transparency, I I think Dr. Pollack's point is about the unique regulatory structure here in Maryland. There's also, not unique to Maryland, great variations in the length of stay for different conditions in different hospitals, which have something to do with the hospital, but perhaps a lot to do with the population it serves. And so that all gets cranked into the average charge for a diagnosis. So that may be another asterisk or point of clarification. So if you go in and you may not have the same average length of stay for reasons you may be shorter in and out or you may be longer, so that it's not necessarily what you will pay. This is really truly an average of what everybody that went into that hospital that year with that procedure, what their charge was. So it rolls up a whole lot of variables beyond what the hospital CFO does.
And not going too far in the weeds, but it is based on APR DRGs where there are 4 severity levels, so risk is taken into account to some extent. So that average is supposed to represent that variation there.
So we'll just drill down on that a little bit more. I think there's more to talk about there. I don't want to be conscious that we have more things to do today. Thank you.
I am very appreciative that we get version 1 out, and then as we keep going, we have version 1.5 and 2 will continue to be better. So I think we're going to get to work groups now, so if there's no further business, I'll entertain a motion to adjourn. Move. Second. Meeting adjourned.